Aortic stenosis. Etiology, pathophysiology, and pathology. Senile, calcific or degenerative. This is the most common form of aortic stenosis, especially in those aged over 65 years. Diabetes, hypercholesterolemia and chronic renal failure are predisposing factors. Coexistent coronary artery disease is common. Congenital bicuspid valve. Symptoms usually appear at the age of 40-50 years. There is a male predominance. Rheumatic heart disease. This is an unusual cause of aortic stenosis. Stenosis results from a combination of fibrosis and calcification, with additional commissural fusion and reduced cusp separation. The increased left ventricular LV pressure load results in compensatory left ventricular hypertrophy LVH and diastolic dysfunction. Subendocardial ischemia and fibrosis is common. Untreated, LV dilatation and failure will occur. There is an increased risk of ventricular arrhythmia. Atrial arrhythmias are usually poorly tolerated. Clinical presentation. Common symptoms are exertional angina, dyspnea, and syncope, and occasionally palpitations. There are symptoms of LV failure if presentation is late. Uncommon. Embolic phenomena from calcific emboli. Gastrointestinal bleeding, idiopathic or angiodysplasia. Infective endocarditis. Physical signs. Cardiovascular examination. Check for stigmata of endocarditis. Pay attention to dental hygiene. Check for signs of heart failure, noting particularly that in cases of aortic stenosis the following may be observed. Pulse. This will be regular, slow rising and small volume due to narrow pulse pressure. Reduced arterial compliance in older patients may negate these findings. Atrial fibrillation is less common than with mitral valve disease. BP, narrow pulse pressure. JVP, prominent a wave. Apex. This is usually undies placed and heaving. It may have a double beat due to additional left atrial impulse. Displacement suggests left ventricular dilatation. A systolic thrill may be palpable over the aortic region and carotids. Heart sounds. The dominant feature is likely to be a harsh ejection systolic murmur in the aortic region, radiating to the neck and loudest in expiration. Typically the murmur quietens across the precordium and becomes loud again at the apex, Galliverdin's sign. First heart sound may be normal or soft. Second heart sound may be single. There is no aortic component from a calcified aortic valve that does not move, or with reversed splitting due to delayed aortic valve closure, if the aortic valve cusps are still mobile. Fourth heart sound may be present. In late presentation, classic signs may lessen and left ventricular failure and secondary pulmonary hypertension dominate. NB. In aortic stenosis, the murmur is not a guide to severity. Look for clinical signs that reflect the hemodynamic significance. Further discussion. The differential diagnosis of aortic stenosis include the following. Innocent systolic murmur, e.g. aortic sclerosis. Pulmonary stenosis. Dominant indications are a murmur loudest in inspiration, palpable right ventricular heave and signs of right heart failure. Usually congenital in origin, e.g. tetralogy of Fallot. Always consider in a cardiac patient who looks cyanosed. Hypertrophic cardiomyopathy, HCM. If you suspect this, look for jerky impulse and a double apex beat. Patients with HCM are often young. NB. Features present in aortic stenosis that would not be expected in aortic sclerosis include low pulse pressure, slow rising pulse, carotid thrill, radiation of murmur to neck, abnormal heart sounds, forceful and displaced apex, unless there is another possible explanation, e.g. hypertension. Symptoms of aortic stenosis include angina, shortness of breath and syncope. Transthoracic echocardiography confirms the diagnosis and enables an assessment of severity. Note, however, that the aortic valve gradient will be underestimated in patients with heart failure, so a dynamic assessment with dobutamine stress may be required in this situation. Coronary angiography is required prior to surgery to look for coexistent coronary artery disease. Patients with mild or moderate disease should be reviewed annually in a cardiac clinic. All patients should be given advice regarding antibiotic prophylaxis against endocarditis. All patients with symptoms due to aortic stenosis require aortic valve replacement because the prognosis is poor for sufferers who remain untreated. In particular, the onset of heart failure is a very poor prognostic sign and such patients should be considered for urgent valve replacement. Mechanical valve prostheses, see Table 11, are generally preferred unless the patient is elderly, increased risks of bleeding on anticoagulation are present, or the patient is a young woman who wishes to become pregnant in the future. In the latter situation, patients will often elect to have a tissue valve. This eliminates the need for teratogenic warfarin during their childbearing years but accepts that valve replacement will need to be performed again at a later date. Investigations. ECG. Chest radiograph. May be normal. Poststenotic aortic dilatation may be seen. Suspect aortic, or mitral, regurgitation or LV dilatation if cardiomegaly is present. Echocardiography. Echocardiography determines whether the valve is tricuspid, bicuspid, or rheumatic in appearance. The degree of valve thickening, leaflet mobility, and calcification, Fig. 53, can be determined. Continuous wave Doppler enables estimation of the pressure drop across the aortic valve and the aortic valve area. Table 27. LVH and LV dilatation with reduced systolic function will be seen with severe disease. Coronary angiography. Coronary angiography will be required in most cases to assess the coronary arteries before surgery. The peak-peak withdrawal gradient across the aortic valve can also be determined. Look for LVH, 85% of cases, and, rarely, conduction disturbance. NB. Consider the following in your differential diagnosis: innocent systolic murmur, pregnancy, fever, anemia, and thyrotoxicosis. Aortic sclerosis. Mitral regurgitation. Hypertrophic obstructive cardiomyopathy. Atrial or ventricular septal defect. Pulmonary stenosis. Treatment. NB. Severe aortic stenosis is associated with a peak gradient of greater than 70 mmHg. However, with LV impairment, the aortic valve gradient may underestimate the degree of stenosis. In this situation, valve area is a more reliable measurement and a dynamic assessment of the valve gradient with dobutamine stress may be required. Emergency. Admit the patient if there is heart failure and treat with diuretics with a view to early inpatient valve replacement. Try to avoid inotropes. Exercise great caution with angiotensin-converting enzyme inhibitors and other vasodilators, and never use them if the patient is hypotensive. Long-term. Follow moderate disease with repeat echocardiography at yearly intervals. Severe stenosis requires closer supervision to detect onset of symptoms. Antibiotic prophylaxis is required for dental procedures, etc. Valve replacement should be considered in all patients with severe aortic stenosis who become symptomatic. It is also indicated in asymptomatic patients who develop LV dysfunction or prior to non-cardiac surgery. Complications. The following are associated with aortic stenosis: cardiac failure and pulmonary hypertension, sudden death, infective endocarditis, embolic disease, complete heart block. Prognosis. Symptoms occur only after the stenosis has become severe. Mild aortic stenosis progresses to severe stenosis in about 20% of cases, 2/3 remaining unchanged. On average, the valve gradient will increase by 4-8 mmHg per year. Extensive valve calcification. The presence of a bicuspid valve and coexistent coronary artery disease predispose those affected to more rapid stenosis progression. Asymptomatic patients have an excellent prognosis. In symptomatic disease, the average survival with angina or syncope is 2-3 years, and with heart failure 1 year.